I know there are long-acting agents out there, right? There's a BLA that was filed in March of 2013 for RF8 FC for the treatment of hemophilia A, and it's the first hemophilia A product in a new class of long-lasting clotting factor therapies. What do we know about this? How long does it last?
Well, I think drugs that are going to be considered to be in the longer acting category of replacement factor VIII proteins will probably have a half-life that's 1.5 to twice as long as the currently available factor VIII products. That has to do with the way factor VIII is cleared once it's administered to a patient intravenously. The factor IX products actually, through various means of fusion or conjugation, are in clinical trials showing a much more impressive extension of half-life, maybe 3 to 4-fold what the available therapies are able to achieve.
So help me out here now in the economics of all of this. We got all the medicine down. We're looking for longer acting agents. I mean, it sounds better simply from a patient perspective.
Yes.
Fewer doses, fewer trips to the hospital, fewer
Right.
IVs. Where does the money come out? Hugh, you want to start on this? I mean, is it worth doing?
Well, we do, again, I mentioned about it, medication adherence, and medication only works when you take it, definitely. And trying to balance, it's a very difficult balancing act. Patrick mentioned primary prophylaxis. One of the concerns also with the primary prophylaxis also is educating patients and helping them with inventory management. So that
Inventory
management.
What
so
is
that you don't get into, because here you are, rather than on demand where you only get the factor when you need it. For prophylaxis, you're getting a supply of your factor every week or every 2 weeks. And we've seen cases where patients have almost a room full of factor. I know that's stretching it a little bit, but where there's a lot of factor that the patient has not used sitting in the patient's home. But with the longer acting, we believe that we could also work with our specialty pharmacies to better manage the inventory that is being provided to patients.
So we have approved agents. You wanted to get a word in on this too, I'm pretty sure.
I did, because in addition to inventory management, we also have the assay management, which is assay. So that gets at the trough level. How much does that patient need to be normal, if you will? So that also minimizes waste. And to the extent that these are high-cost patients, and the drug is a big component of that, how do we minimize the waste? And how do we
Nobody wants to waste drugs,
Exactly.
right? But nobody wants people to bleed either. So it's a balancing act,
It's a
right?
balancing act.
So how do the per use and the lifetime costs vary for the approved agents that are out there right now in terms of safety and efficacy? Who wants to weigh in on that?
Well, I think all of the approved therapies are safe. There is a sort of bump up in per unit cost which occurs when an individual goes from using a plasma-derived product to a recombinant product. The recombinant products are more expensive than plasma-derived. Mm-hmm. Most pediatric patients, children, toddlers, et cetera, adolescents in this country are on almost exclusively recombinant therapies, whereas among older populations of individuals with hemophilia, it's kind of a mix.
I think when we mention safety, I may be the only one old enough here to remember when AIDS hit America. And to a very real degree, the hemophiliac population in this country was wiped out. A huge percentage got sick and eventually died. This is a new era. These things are safe, right? All these drugs.
It's true, yeah. There hasn't been a case of a sort of transmission of a sort of life-limiting or serious viral pathogen since 1986. And so it is a matter of great concern that drugs that are brought to the market be safe, and I think there's a long track record, fortunately, for recombinant therapies of safety.
Is everybody using the drugs the same way? Or is there a variation in clinical practice, patient to patient, individualized, center to center in terms of these drugs?
Well, I can tell you, for instance, in some centers, and this is something that some Canadian hemophilia treatment centers have promoted, there is an effort to identify sort of the least amount of factor a patient would require in order to prevent spontaneous bleeding. That one way of doing that is a method called tailored prophylaxis. Some people think that going through that process will lead to just really an excessive and unacceptable amount of bleeding in a child, because you almost have to prove that a minimum dose doesn't work before you go up to the next frequency of administration. But patients are going to have preferences, providers are going to have opinions, and parents, when they're the ones who are stuck placing an IV or managing a port, are going to have a say in just what's feasible for their family.
But are they? Or are you going to take that say away from them, analyze what he's telling you, analyze these studies and say, no say, this is what you're going to do or we're not going to pay for it?
Well, I think it gets back to the shared decision making, but also the cost, and how do you individualize that risk versus benefit, so that for some patients you may want to pay more for a drug that truly is effective in terms of preventing the bleed, right, given the patient's history, given what they need. But when you first start off, it's very interesting to me, because how do you, brand new patient, treat what we call treatment naive, how do you start off with what is that right treatment for that patient?
Right.
I think it's a very different scenario when you have inhibitors, and that raises an even bigger question around cost and what are the options there.
Right.
But initially, what's the best practice around what can you start off with, and how is the decision made?
Who's going to make that decision, you or you?
We usually like
It better be a partnership, because we want to make sure that all patients with hemophilia have access to these drugs, and that they're getting them in the best way. And there are just a variety of ways that centers, individual centers would do this. The goal is that all children be on some kind of prophylaxis for sure.